Oh, great. I see a lot of people coming in from all over the place. It's amazing to continue to connect with you all. We're like physically distanced, but socially connecting. And as you know, it's been a passion of mine to try to keep people socially connecting. So hopefully you're doing that in your own neighborhood. So I know the weather's getting better. You're getting outside in nature, trying to find friends, find neighbors, maybe go for a walk. We're just hoping to, continue your wellness pursuits. So excited today to have Roseanne Dobkin, who I've heard about for years and seen lecture and just been a big fan of her work, come on the series today. And she's an amazing colleague. She does work in the VA and outside the VA as well. She's a professor of psychiatry at Rutgers, and she is also an amazing psychologist who's done a lot of work in cognitive behavioral therapy, which we'll learn a little bit more about, and depression, and has really had a passion that she shares with many of us for mental health and Parkinson's. So excited. Welcome, Roseanne. And maybe you could tell us a little bit about your journey to getting to where you are and why you love to take care of this population.
Oh, thank you. I'd be happy to. And thank you so much, Indu, for having me here this morning or this afternoon, depending on where we're located. As Indu mentioned, I am a licensed clinical psychologist and a professor at Rutgers. I actually started at Rutgers many moons ago. Back 2002, I did a fellowship there, and then I stayed on as faculty, and it's been such an amazing place to build a career that I haven't left yet and ventured elsewhere. But, prior to coming to Rutgers, I was trained in health psychology and behavioral medicine. And I had always been very interested in the mind-body connection and the very clear interface between physical well-being and emotional well-being. And I had worked with a lot of individuals with other types of chronic medical conditions at earlier phases of my training. And when I joined the Rutgers team in 2002, at that point in time, unfortunately, things have changed and improved since that time. But at that time, we were the only movement disorder specialty center in the entire state of New Jersey. And we're also fielding referrals from many states across the Northeast. And there was a really great need that was brought to my attention for improved mental health care for individuals with Parkinson's disease. So I raised my hand and I said, sure, I would love to sit down and work with people one-on-one with PD to improve quality of life and mental health and emotional well-being, and to do all the things that Indu referenced a few moments ago in terms of decreasing loneliness and isolation, and empowering people to be proactive in terms of their own self-care, and really taking charge of disease management and exercising control in all of the very many areas where you have it. And in addition to my passion for doing clinical work, I started to consult the literature and realized that there were very few people at that point in time that were doing research regarding non-motor symptoms or mental health aspects of PD, and virtually nobody was looking at the impact of behavioral interventions or talk therapies, non-medication approaches to help improve concerns like depression and anxiety that are so common and functionally relevant. So in addition to my passion for clinical practice, I started a research program in that area, which I'll talk a little bit about today, that has really, I think, taken off and been, transformative in a lot of ways. So very happy to be here and to be able to discuss that in greater detail over the next hour.
Yeah, no, so excited. No, I think this is amazing work. And I think the pandemic has sort of shone a light on a lot of the need for this that was already existing, but we've sort of stopped and paused and realized how important this is. So I think I'm excited to speak to you about that today and work on, this other initiative that we're having around wellness and mental health as well with our consortium that we're starting to form worldwide. So stay tuned, our listeners out there. But yeah, maybe without further ado, thank you for giving us that background as well. It's so interesting to learn about why people do what they do and sort of the unmet need, and how you've really, been a pioneer in the research and honestly, the clinical care in this sort of arena. So love to sort of have you share your slides. I know you put together a slide deck that I reviewed. It looks amazing. And then we'll take some Q&A and sort of more broad discussion after.
No, that sounds great. So like I was telling Julie, I've been living on Zoom. So hopefully when I go to screen share, this is going to work seamlessly, but if not, we'll figure it out together. So give me a second to pull this up. And then I just have to switch it to slide show presentation. Let me just move this over. I have to move this top toolbar. There we go. Okay, can everybody see that okay?
Yep, perfect. Mm-hmm.
And we're in presentation mode, so you're not seeing like all sorts of scribbles and notes, so we're in good shape. Okay, excellent. So I'm going to be speaking with you about non-pharmacological and virtual treatment of depression and Parkinson's, but at the end of the talk, I'm more than happy to answer any questions that you have related to health, wellness, quality of life, and self-care, because I could talk about those topics all day long. And this next slide is just my disclosures related to some grant funding that I've received, but I think the point I just want to get across is that I have no conflict of interest related to this presentation. And like I mentioned, thrilled to be here chatting with you today. So in terms of objectives for our chat today, I'm going to first start out by briefly describing, the prevalence and impact of depression and Parkinson's. Then I'm going to review some data related to the application of one specific type of psychotherapy that I do called cognitive behavioral therapy to the treatment of depression and Parkinson's. And then I really want to highlight the promise of telemedicine to leverage access to informed mental health care for the PD community in general. And I'm also going to talk a little bit about veterans with Parkinson's because I do some work at the VA in New Jersey as well. Okay, so what do we know about depression and Parkinson's? Well, we know that depression is common and it's functionally relevant. Statistics suggest that depression affects at least 50% of people with Parkinson's. I would argue it's probably even a little bit higher than that. And unfortunately, we know that depression has significant negative effects on people with PD and their family members. These negative effects include faster rates of physical and cognitive decline, earlier initiation of dopaminergic replacement therapy, medication non-adherence, greater risk of falls, increased health service utilization and costs, poor quality of life, and increased rates of caregiver stress and burden. But despite these really detrimental outcomes, depression, as well as other mental health concerns like anxiety, are underdiagnosed and suboptimally treated. So it's been my passion to argue and to develop and to promote, effective and accessible treatment approaches for the PD community related to mental health concerns in order to optimize overall global PD outcomes and improve total Parkinson's management. So these next slides underscore, I think, the importance and the magnitude and the scope of the difficulties that we're talking about. I'm not sure if everybody on this call is familiar with the Fox Insight study. And if you are familiar, I hope that you are participating. And if you're not familiar or participating, then look up Fox Insight. If you just Google the name of that research program, it will pop up on the Michael J. Fox Foundation website. But essentially, Fox Insight is an online study that collects information from individuals living with Parkinson's disease, as well as their family members, as well as those who are not affected by Parkinson's, and looks at the relationship between mental health outcomes, physical health outcomes, quality of life, and other overall health indicators. And in the Fox Insight study, what we have learned so far is that while a significant proportion of individuals who have provided data, and we're talking about large numbers, this is an international study, and at this current time, about 50,000 individuals from around the world have provided data so far. Looking at that data, and the numbers on this slide, I will just take a step back and say this reflects data that was available back in February of last year. So these are not the most updated numbers because numbers are changing, on a minute-to-minute basis, but I think they're pretty reflective of the trends and the patterns that we see. So we saw a significant proportion of individuals endorse depressive symptoms. And of those individuals who endorsed depressive symptoms at either the mild, moderate, or severe level based on this one screening measure that we use known as the Geriatric Depression Scale, as the numbers will show you, the overwhelming majority were not treated. So of individuals who endorsed and again, I'm going to put mild in quotes because this is mild defined by, psychometric properties of a scale, not necessarily mild from the perspective of the individual that's dealing with the symptoms. But about 60% of individuals who scored, a 5 or higher on this depression screening scale were not being treated. And even as depression severity indices moved towards the moderate range or the severe range, we're still having more than 40% of individuals who have not received treatment for their depressive symptoms. And then as this next slide shows, again, still in the same sample, unfortunately, the rate of treatment versus no treatment didn't really differ by location or type of care. So individuals who are seeing movement disorder specialists versus those who are seeing general neurologists, those seen in academic medical centers versus, let's say, the VA or other types of private practices, unfortunately, it didn't matter. The rates of suboptimal treatment remained, as you see, independent of the level and the location of care. So specialists weren't doing any better with respect to assessing for and detecting and treating depression and anxiety than non-specialists. So what do we know about treatment? So what is available? What are the types of treatment that we may want to speak with our doctors about if we are feeling or experiencing symptoms that may be uncomfortable or making life harder than it needs to be? So antidepressant medications are the typical first-line intervention. These medications are wonderful for some people, but they do not work for everybody. The research data suggests that in addition to working for some and not working for others, sometimes individuals might not want to take, yet another medication. And sometimes these medications can have side effects. Many older adults, as well as people with Parkinson's, have shared that they prefer non-medication approaches for concerns like depression and anxiety, or combination approaches, such as possibly taking the antidepressant and receiving some type of evidence-based psychotherapy, like cognitive behavioral therapy or CBT. So I'm going to spend some time really breaking apart concepts that fall under the umbrella of CBT and talk not just about, what this psychotherapy package looks like if you were to seek help from a trained professional, but also how you can incorporate a lot of the principles that are CBT-like into the context of your day-to-day, even if you're not interested in working with a mental health professional. There's a lot of this that you can incorporate in your own, at home, in the context of your daily lives that can really enhance overall quality of life and well-being. But as far as the data goes, my team has conducted 3 fairly large randomized controlled trials to date, looking at the impact of CBT, not only on depression, but also anxiety, quality of life, physical functioning, motor disability, a whole range of related PD outcomes. And these studies have been fairly large for studies of this type. Sample sizes have ranged from 72 to 90 participants. And across all of these studies, again, which I will break down kind of one at a time, we saw really nice significant reductions in depression over a period of 6 months. And we also saw really nice improvements in anxiety, quality of life, physical functioning. People became more active, more engaged in their day-to-day. They were more social. Their symptoms did not have as great of an impact on their activities of daily living. And also, quite importantly, they weren't as hard on themselves. They weren't criticizing themselves or beating themselves up because of physical limitations associated with Parkinson's, but rather they were working to figure out how they could live the best life possible, fullest possible life, even with Parkinson's coming along for the ride. So when I talk about cognitive behavioral therapy, I know it's this complicated, jargony psychological term, so you might be thinking, what in the world is she talking about? So let me try to break it down. These are some examples of individualized interventions that we may do in the context of CBT. But I'm also, again, just put it out there that everything that I'm sharing on this slide, may give you some ideas related to practical tips and tricks that you may want to, incorporate into your daily lives, into your daily routines, maybe even starting immediately after this presentation, because why wait? So one of the first things that we do is we work in a very collaborative, very personalized way with each individual that we're speaking with to develop a plan to increase their involvement in meaningful and social activities. And I don't mean being busy for the sake of being busy, because that is not helpful. But in order to both prevent as well as to treat concerns like depression and anxiety, we need to have enough exposure to people, places, and things that give us an opportunity to feel good about ourselves in the course of our daily routine. And the more exposure we have to those people, places, and things associated with positive emotions, the better we're going to feel. So sometimes we will work with people to figure out, were there some activities that maybe you used to really enjoy that have just fallen off the radar, for no particular reason, so maybe you used to, do I'll use pandemic talk, maybe you used to do a weekly Zoom with your friends and family when the pandemic started, but now you've stopped, or they're still meeting and you stopped joining. Well, let's talk through that and figure out why, and how maybe we can get that weekly Zoom, back into the daily or weekly schedule. So, maybe there are old activities, again, that there may not be any clear reason as to why they've fallen off the radar, and we can work collaboratively to get them back on the schedule. Sometimes we may need to find new activities, to do mini experiments to help an individual figure out, what are some new things I can test out or try and see if I like it. Maybe I'll go to that rock steady boxing class and I'll test it out and I'll commit to it for a month. And then after a month, I'll evaluate how I feel about it. And if I like it, if I feel empowered, and if I feel in control, then I'll stick with it. If I don't like it so much, then maybe I'll table it and I'll look for a different exercise class, or I'll look for a different opportunity to connect with the community. So it's about testing out new things, figuring out how we feel about them, figuring out, what's the emotional impact of this choice? What's the physical impact of this choice? And then taking it from there. And sometimes it might be a modified activity. So I know many individuals that have had to change the way in which they've engaged with certain activities because of some of the physical challenges that Parkinson's presents. But it's so important to figure out, how can I problem solve around those physical limitations rather than, throwing your hands up in the air and giving up altogether. And when I talk about this, new creative ways to engage with old activities, I like to share a story that I've got permission to share from my friend Howard. So Howard is a person with Parkinson's that I worked with probably closer to the beginning of my career, 2003, 2004. And this is such a wonderful story that I continue to share it after all this time. And Howard worked as a volunteer firefighter for decades, probably 30 or 40 years. And I started meeting with him for regular cognitive behavioral therapy sessions about a year or so into his Parkinson's diagnosis. And things were getting to the point where it was no longer safe or recommended for him, to go out and respond to calls. And to show up on the scene of the fire. And as a result, he became very, very depressed. And he really withdrew from all activities associated with being a volunteer firefighter. And he really wasn't keeping up with all of the really important friendships and social connections that he had made in the context of his work on the fire department. So with time, And with some really nice conversations and ongoing collaborative psychotherapy, Howard came to the point where he was ready to think about maybe alternative ways that he could connect with that fire department. So no, it wasn't, going out and fighting fires, but were there other ways in which he could still contribute or find value in that opportunity? So with some hesitation, Howard agreed to do some experiments. And in his particular firehouse, everybody would get together on Thursday nights for like a standing meeting. But the meeting was very brief, and then people usually kind of hung out and had coffee and, played pool or ping pong or just shared stories. So even though he was a bit unsure, he agreed to maybe show up for one of those Thursday night meetings and just check in with everybody else in the department and see what that was like. And that was met with some good success. Everybody was really happy to see him. And so we reported back, oh, that actually wasn't so bad. It was better than I thought. It was easier to reconnect than I thought it would be. And so he agreed to continue going on Thursday nights. And that worked out really well. And then a couple of months later, the department was hosting a chili dinner to fundraise for the department. So he says, you know what, maybe I can help. I'll go and I'll collect money at the door as people are coming in, and I'll see what that feels like. And again, he had a very nice success experience. He felt like he was being productive and he was contributing. And then over time, he started taking more and more of a leadership role in the other volunteer and fundraising opportunities that the fire department offered. And over the next 6 months, Howard went from being, a very concerned participant in the Thursday night meetings to the chair of all of the fundraising initiatives that local fire department led. So Howard was able to recognize that even though he was no longer able to go out and fight fires, there are so many ways that he was able to make an amazing and valuable contribution. And he ended up, maintaining that role as fundraising chair for the next 5 years. And throughout his tenure in that role, he was able to bring in more money in terms of donations to the department than any other individual in that role had previously been able to achieve. So I really love to share that story for that reason, because he was able to stay connected to a really meaningful, really important activity in his life that gave him a tremendous sense of purpose and direction and accomplishment, but he stayed connected in a very different way, at the end of his career with the fire department, very different in the way in which he had connected in the earlier parts of his career. So we always want to think about, do we have enough in our day to fill, our buckets in terms of meaning, in terms of purpose, in terms of feeling good about ourselves. Exercise goes without saying. When I'm working with individuals, I love to collaboratively problem solve around how we can get exercise into our routine most days, 5 to 7 days a week. And it doesn't have to be, running or something that is unsafe or physically not possible, but any type of exercise is better than no exercise. And research has shown that exercising at a moderate level of intensity for about 45 minutes, 3 to 5 times a week, has comparable effects to antidepressant medication. So exercise is really, really important. And then I've mentioned this, earlier in this talk as well, problem solving around physical limitations such that we can increase our involvement in meaningful and social activities. We can exercise more. We can be more connected to other people. So what does problem solving look like? It might mean pacing of our activities. It may mean setting, appropriate daily goals with less rigid demands. It may mean that we plan around our off time. Or we have to break things down and approach the activity differently. So maybe walking 10 minutes 3 times a day instead of 30 minutes at a time. Following through with referrals for other types of PD-related multidisciplinary care that may be offered, like PT, OT, and speech. All of those services will help us to stay more engaged with activities that mean a lot to us, will keep us more connected to the people that we so very much value. So oftentimes the folks I'm working with will tease me and they'll tell me that I'm mean because I always share with them the Dobkin 3. And the Dobkin 3 relates to goal setting. And I usually encourage all of the folks that I work with to set 3 goals per day. One goal, of course, right off the bat is going to be an exercise goal. Could be anything. Could be a chair yoga class. It could be the 30-minute walk. Anything counts. The second goal that I suggest everybody incorporate into their daily routine is a social goal. And when I say social goal, it doesn't have to be hosting a dinner party for the entire neighborhood, but anything that's going to afford a meaningful social connection with another person. So it could be as simple as answering the phone when it rings, if a relative's calling, rather than letting it go to voicemail. It could mean going out of your way to have a 2-minute conversation with a barista at Starbucks. Anything that's socially going to connect you to another person. And then the third thing that I usually put on my hit list is anything else that is going to give you the opportunity to self-soothe or feel good about yourself. Listen to your favorite music. Carve out an hour in the day to soak in a hot tub or to read a book, but something that's just for you, that's associated with meaning, pleasure, and enjoyment. So the top 3, exercise, social connection, and something just for fun because it feels good for you every single day. Some other things that we incorporate into our cognitive behavioral treatment programs. So we do a lot of anxiety management and relaxation training. So we will teach people different breathing exercises, progressive muscle relaxation, some visualization techniques, as well as some worry control techniques. So I want to talk a little bit about worry control because this is a really interesting concept. So oftentimes when people worry, the worry spins and spins and spins, and it can kind of take over the day. The idea about worry control, and this may sound silly, surface level, but I promise you it works if you try it. If you're somebody that worries a lot, what some of the worry control techniques would suggest trying would be this. Picking, let's say 2 times a day, I'm going to just make this up. Let's say 9 a.m. in the morning and 6 p.m. in the night. Give yourself 20 minutes. And during that time, you're basically scheduling your worry. So from 9 to 9:20 every day or 6 to 6:20 every evening, you're not going to do anything else other than worry. If the worry rolls through your mind, at other points during the day, which it will, rather than dwelling on it at that point in time, we're going to kick the can down the road and we're going to think about the worrying thoughts, not until that scheduled worry time. So the idea behind this approach is kind of twofold. The first is if the worries are so important, well, then they deserve dedicated time where you're not going to do anything else other than focus on them for a very short period of time. And then also we're going to postpone worries when they come up at other times during the day. And it's the act of postponing the worries, that delay over time will decrease the saliency and the importance of the worries. So something to consider. If you're really worrying, carve out 1 or 2 times a day where you're going to focus for a short period of time just on those worries. And if the worries pop in at other times during the day, it's the one time that I'm going to give you the opportunity and permission to procrastinate and kick the can down the road and think about it during that scheduled worry time, because we don't want worry to take up the entire day. And if the thoughts are there, they're there. So let's focus on them during very specific periods of time so that we can enjoy life during the other periods of time. Sleep is really important. You know, if we get a good night's sleep, we always feel better. We're always better prepared to deal with the challenges that each day presents. So some key tips related to sleep hygiene. You know, we want to use our bed for relaxing activities, not stressful activities. So we don't want to go to bed with our laptop and try to figure out how we're going to do our taxes, or, you know, how we're going to respond to maybe to a less than favorable email that we got from our in-laws, right? That's going to be too stressful. So we want to use the bed really for sleep only. I think it's wonderful if people can find time in their schedule to relax at least 60 minutes before bedtime. That may also mean limiting screen time, not being on devices late at night, because that can be very stimulating. Trying to keep regular sleep hours. It doesn't have to be to the minute, but we want a sleep schedule. We don't want our bedtime and wake time to vary greatly every single day, because then it's going to be hard for our bodies to develop healthy sleep habits. You know, so maybe we go to bed in general, you know, whatever time that works for you, about 11 p.m. every night, you know, give or take 30 minutes. And we try to get up about 8 a.m. every day, give or take 30 minutes. And we want to limit, you know, excess time in bed during the day. You know, a very strict sleep behaviorist would tell you don't nap. I'm not going to tell you not to nap because I know that that is not reasonable or feasible or practical given the amount of fatigue that people with Parkinson's can experience. But what I will tell you is that if you're somebody that likes to nap, I would strongly suggest scheduling your nap. So you're taking the nap, you know, about the same time every day. So let's say 2 p.m. versus sometimes it's 11 o'clock in the morning, sometimes it's 2 o'clock, sometimes it's 5 o'clock at night. We want the nap to be about the same time every day. And we really don't want the nap to run longer than 90 minutes, because that's when naps can start to really wreak havoc with nighttime sleep. But a shorter nap at the same time each day can sometimes be very restorative and very helpful. Now I'm going to talk a little bit about the cognitive intervention. So what's the C in CBT? You know, I've been talking a lot about the behaviors, you know, the increasing meaningful and pleasurable activities, and the social connections, and the exercise, and problem solving, and, you know, learning how to meditate, or some breathing techniques, or some visualizations. But what about our thoughts? So we spend a lot of time in cognitive therapy helping folks to figure out what they're saying to themselves and how to catch the negative thoughts, press pause, rewind them, and then replay them in a healthier, more balanced direction. Because the reality is we are all constantly thinking all of the time. We're constantly making meaning. We're constantly interpreting what's going on around us. And nobody is ever stopping to think about what they're thinking about, unless you have somebody like me asking you, what was running through your mind right now? What was so bad about that? What did that mean to you? But we're always talking to ourselves. And the unfortunate reality is we are a lot harder on ourselves than we ever would be on our friends and our family. So we really want to be mindful of what are the words that we are using? What are we saying to ourselves? Take out that mental remote control, press pause, rewind it, think about it a little bit more deeply, and can we replay it in a more balanced direction? And there are lots of techniques, lots of methods that an individual can use to balance out their thinking. And I'm going to say right now, and this is a pet peeve of mine, I do a lot of training, you know, with medical students and graduate students and psychiatry interns and residents. Cognitive therapy is not the power of positive thinking. It is the power of realistic thinking. We want to catch negative thoughts that are based primarily on fear and emotion, not on fact, and take them from that extreme negative closer to center. It's not about being, you know, Pollyanna, pie in the sky, you know, it's all sunshine and roses, because that's not the case. But we want to have balanced, realistic, practical thoughts that will empower us to deal with all of the challenges that we face day in and day out in the healthiest, most adaptive of ways. So as I mentioned, there are lots of different techniques, but I'm going to share with you another case example, again, shared with permission, not from Howard this time, but from my friend Bill. And this is a technique called examining the evidence. So the idea behind this technique is you catch the negative thought. which in Bill's case was I'm helpless. And then you evaluate, okay, what are the facts that support the thought? What are the facts that don't support the thought? And if we compare the information that's on both sides of the equation, is there a more balanced, more rational way of looking at the situation? So Bill and I had been working together, also earlier in my career. And we were meeting at that time every Thursday morning, 10 o'clock for weeks. And, Bill had been making a lot of progress in his work with me. And one Thursday morning, he came in, looking more demoralized and depressed than I had seen in a long time. And so we started to talk through, okay, what was happening, what was going on, what led to this really negative emotional shift. And, Bill had been living with PD 10 or 12 years at this point and was really experiencing a lot of difficulties with freezing. And so he basically looked at me and he's like, Roseanne, I just want to throw my hands up in the air. He's like, last night was horrible. I've never felt so helpless. And I said, well, tell me more. What happened? So he shared that, per usual, he got up in the middle of the night around 2 or 3 a.m. To go to the bathroom. And he's at the sink washing his hands, getting ready to go back to bed. This was a hall bathroom. And so he had to make his way, across the hall back into the bedroom. And he was frozen. He was unable to move his feet. And he's standing there alone. His wife's asleep across the hall. And he's feeling, really stuck and scared on the cold bathroom floor. So we talked through what happened. And I also want to say, because this was many years ago, this real life example is shared from a period of time when we were not as attached to our cell phones. iPhones did not exist. So it's going to make the next part of this case example, I think, all the more impactful. So he's alone. He's frozen at the sink. But what Bill had been doing, because he was having many of these freezing episodes, is he was wearing his cell phone in whatever form it existed at that point in time around his neck. He never went anywhere without it. So what he did was he called his wife on the house phone, because yes, they still had home phones at that period of time too. He woke her up and she came into the bathroom and she helped him to practice his PT techniques in order to break the freeze. And he was able then to get himself back to bed. So after we talked through it, Bill was able to recognize that even though he was physically unable to move his feet, he was able to help himself out of the situation. Therefore, he was not helpless. And that was a pivotal point for Bill, because after this session, he really was able to kind of take a step back and not accept some of his negative thoughts as the absolute truth, but to look at them more closely to see if there are any opportunities to maybe widen the lens and to consider some alternative perspectives. So here's a summary sheet. And again, these are real life examples of thoughts that I've worked on with individuals with Parkinson's disease. So the idea would be to take a negative thought that somebody might be having, like I'm not accomplishing anything anymore, and then look at it more closely. Maybe we would do the evidence for and against, or maybe we would do a mini experiment to test out the validity of the thought, or maybe we would ask a friend for their opinion related to the accuracy of the thought, or we could identify and think through, the pros and cons of the thought. The list of techniques goes on and on and on. But the idea of the cognitive work is to take a thought like I'm not accomplishing anything anymore, pause it, look at it more closely, and then based on the evidence, come up with a thought that's more along the lines of, well, I'm still accomplishing many things for my family and community, even though I'm no longer working in my business. Or taking a thought like I'm rapidly deteriorating. And then after, performing some type of work on the thought, looking at it more closely, coming up with a reframe like the neurologist said that I was the same that I was 6 months ago. Exercise is helping to keep my symptoms stable. So therefore, I am not rapidly deteriorating. And there's more examples as well. Now I want to just quickly share results from some of the studies that I mentioned that my team has conducted over the past couple of decades. So the first study that I did was a traditional brick and mortar trial where individuals had to come into my offices in person. We sat in the same room together in the same physical space, and individuals received 10 weekly sessions of cognitive behavioral therapy. And we followed and assessed their symptoms and how they were feeling and functioning related to all aspects of Parkinson's care over time. And I will just mention this was a randomized controlled trial. This particular study had 80 participants, and individuals were randomly assigned to either come in and meet with my team for these weekly individual sessions, in addition to continuing any other treatments for depression or anxiety that were being recommended by their personal physicians, or those who were randomized to the usual care group just continued to receive all of the therapies that were currently being recommended by their personal health care team. And those individuals who were assigned to that usual care condition did get the cognitive behavioral therapy package after the evaluation period for the study had ended. So after individuals completed all their study assessments and then a follow-up assessment about a month after therapy ended, we did offer people assigned to usual care the opportunity to receive the treatment. So nobody was denied or deprived of the chance. And what we found is that individuals who received the cognitive behavioral therapy did much, much better with respect to improved depression outcomes over time. The green line represents individuals who received the CBT. The red line represents individuals who continued to receive just treatment as usual. And what we see is that those who received treatment as usual, their symptoms unfortunately didn't change or improve much over the period of the study. Whereas those who received the CBT plus treatment as usual, they experienced about a 7.5 point decrease in their depressive symptoms based on this one rating scale. And that's a pretty significant effect. And again, for this particular study, it was 10 weeks of treatment and the follow-up period was 1 month later. And then we looked more closely at, well, what type of depressive symptoms, responded best to therapy. So we found that all symptoms of depression responded really well to therapy, but there were certainly some that responded better than others. So the core mood symptoms, like feeling sad, decreased interest and enjoyment from daily activities, really having to push oneself to go and do, not having that zest and enthusiasm, feeling less productive. Those were the symptoms where we saw the biggest change, the biggest impact. But we also saw some nice changes in the anxiety associated with depression, the worry, the excessive focus on physical symptoms, what bodies were doing versus not doing, as well as some improvements in sleep and somatic symptoms like appetite and fatigue. And then like any good researcher, we looked at these changes not just on one measure, but also on two. And it's nice when our results mirror each other. So on the second measure, we found, again, very similar results, that people's negative attitudes improved, the functional impact of their negative mood on their activities of daily living was very much reduced. So people were more able to effectively engage in their day. They weren't as slowed down or negatively impacted by their mood. And we also saw some improvement in somatic symptoms, though again, not as large as we saw in these other symptom domains. So in the context of doing this work, though, we also realized that there are big access problems. When you have resources that are provided to you by an NIH grant, you can jump through hoops. We were sending transportation to bring people to their appointments. Sometimes I was sending graduate students to do home visits if there was no other way to get the person requesting care into the office. But in the real world, it's not so easy. You don't have unlimited budgets to do this type of outreach. So I really wanted to kind of fact check myself, and I wanted to see, is this a function of New Jersey? Is this a function of Dobkin, or is this like a broader, more systemic problem? So back in around 2013, we did a larger survey nationally of the Parkinson's community online. And what we learned was that about 93% of the individuals surveyed really believed that mental health care was integral to Parkinson's management, but 60% had no idea how to access local mental health care. And again, this problem also extended to the veteran community. So then I thought, I need to figure out, how what we've been doing in person and how to use telemedicine in order to make these therapies more accessible to everybody in the Parkinson's community that feels like they could benefit. So I was a huge advocate and proponent of telemedicine, decades before COVID. Now everybody else is kind of starting to catch up, and we're all becoming a little bit more aligned in our thinking. But I did 2 studies, and I looked to see first, if with appropriate modifications that we could provide the same high quality mental health care over the phone as we did in person. And then I also looked to see if we could provide the care using web-based video conferencing, because I really wanted some data related to the impact and the effect of treatment using a variety of telemedicine options. So these next data slides review the results from the telephone-based study first. And what we found was that we saw really, really nice reductions in depression when this exact same intervention was administered by phone with appropriate modifications. And again, had 2 measures, because any good researcher, you can't just have one, but on both an interview measure of depression as well as a paper and pencil measure that participants completed. Rates of change were really large. And individuals who received the cognitive behavioral therapy, in addition to usual care, did much, much better over time than just those who continued to receive usual care. And in this study, as well as the video study that I'm about to talk about, the 6-month follow-up period was extended from 1 month to 6 months. And so even over that longer period of follow-up, the effects were still maintained, which is really nice to see. We also saw nice response in anxiety. And then there is a 3rd study that I mentioned that I don't have slides on because, again, they're almost identical, but we administered this treatment via video conferencing to another 90 individuals with Parkinson's. What this slide shows is that the magnitude of change on our primary measure of depression was almost identical across these 3 studies. Like if I made up the data, I don't think it could look this good. So what we found was that whether or not we administered the treatment in person, in the office, or over the phone, or using live web-based video conferencing, we saw large, meaningful, sustainable improvements in depression, which is what's mapped on this slide. But again, I want to underscore, we didn't just find these effects for depression. When we improved depression, we also saw really nice, meaningful, big changes, big improvements in quality of life, social interactions, physical functioning as well. So when we improved mood, we saw really nice improvements in many other outcomes to enhance quality of life in Parkinson's. So what does all this mean? Well, what this means is that there are many ways to take charge and to be empowered and to be proactive in your self-care. And that by doing so, we can really impact quality of life and potentially, change the course of PD progression over time. So I always like to interject, well, then how do we know, right? How does one know if they need to potentially, talk to somebody about how they're thinking and feeling? So I just list out on these slides some self-assessment questions that an individual can consider. So is your mood as good as you'd like it to be? Think about your average day step by step. What activities are you engaged in that are associated with feelings of meaning and satisfaction and productivity and pleasure? Are you socializing? Are you exercising? Are you engaged in hobbies? Are you engaged in other leisure activities? Are you volunteering? Are you working full-time or part-time? Think about, how would you describe the activities that bring you meaning, joy, and pleasure? Has anything changed since the diagnosis of your Parkinson's? Are you less active than you once were? How are you coping with the many, many challenges that Parkinson's presents? And might there be some room for improvement in some of those coping efforts? And then lots of questions to think about if you're a worrier. Does worrying take up a lot of time? Does it interfere with other activities? Does it weigh heavily on your mind? Does worrying or anxiety, does it take away from your enjoyment of life? Are you guided by fear in terms of what you do or what you don't do, rather than by your goals and your values? Are you overestimating the probability of danger? Are you frequently anxious about the unknown? Do you predict the future negatively? Do you often focus on the worst case scenario? And some themes that I have found helpful to guide self-assessment. So typically when I'm working with individuals who are newly diagnosed or in the earlier stages of PD, consider, are you overestimating, the extent of physical disability or functional limitations? Oftentimes in early PD, people can do a lot more than they think they can. So it's important to consider that. And in more advanced PD, are you underestimating your ability to cope with the challenges that Parkinson's presents? So these can, again, be some really important questions to consider, to think about, and based on your answers, maybe will dictate whether or not it's helpful to potentially reach out to speak to your neurologist about a referral to a mental health professional. I also list self-help books that can be particularly useful. These are all books that I have read and I found a lot of value in. They'll take you kind of step by step in much more detail than I had the opportunity to share today about how to implement some of these practical tips and tricks into your daily life. And then in conclusion, I'll just say before I take some questions that, your mood is one critical aspect of living with Parkinson's that you can control. Please do not suffer in silence. If you feel something, say something. Effective treatments are available, be they in person or via telemedicine, self-help, or with a mental health provider. There are treatments that are out there. We can do better. We can do a much better job as a community assessing, recognizing depression and anxiety, and helping to match people up with a type of treatment that's going to best meet their needs. So I am going to stop there, and I'm happy to take any questions that people have in the time that's remaining.
That was so awesome. Thank you so much, Roseanne. Wow, what a great comprehensive talk. I didn't want to interrupt you at all, but the time flew by. We have like 6 minutes left. I think we could talk about this for hours and hours, but I loved, the empowerment, getting educated, understanding these concepts of, sometimes just worrying about things over and over, getting in the mind, and then also worrying too much about the future and things that you don't have control over. Replacing pills by strategies that you can, sort of implement on your own sort of purpose and meaning and things like that. So important. So many things resonated with me in that discussion. I think it would be amazing to have, honestly, a workbook for our Parkinson's patients that they could kind of learn about this and kind of call things. So happy to work on anything like that, because I think it's so important. So, I think so many of these things are important. And, I think therapists are few and far between, and many of the therapists that I know themselves need therapists because they're so, spread thin, especially during the pandemic. So I think many, many important things you touched on. So, and our audience just loves all of this. So, so there's been some questions about, are there, finding therapists? So maybe you could refer us to a website where you feel that are, relatively, I know you don't know every therapist out there, but if there's, a place, and I think we're also, you and I just speaking about, trying to gather people that are interested in this field as psychologists and psychiatrists. There's not that many, honestly, out there. So your work is just so important in trying to disseminate these resources. But I really applaud you for trying to break it down to meaningful bits that are, teachable, hopefully, and accessible to everyone that's listening out there. And hopefully we can work together to get more of this knowledge out to folks. One thing that you and I had spoken about, maybe, and we have 4 minutes left, is the secret sauce to what makes a patient succeed. And I know that you've spent a lot of time telling us anecdotes about different patients and obviously been touched by many of them over the years. If you had maybe a couple of things that you could kind of encourage people to do, or what do you think is that secret sauce? Maybe you could just break that down in just sort of the last few minutes that we have to give some inspiration. And the one thing that I also loved was that doing something that you enjoy or that brings you pleasure every day. I think that all of us could do something like that. I mean, I think, in the drudgery of life and just sort of getting through the day, we kind of forget the things that are, so meaningful to us. Sometimes like basic, just a nice warm cup of tea, or like you said, soaking in a bath or whatever. So I think we all have to stop and do that a little bit more. So, so maybe tell me the secret sauce. And then people have really liked the Dobkin 3. I like that too. I might use that.
So the Dobkin 3 is, I think some critical ingredients to cooking up that sauce. I think it's really about being proactive in your self-care, asking questions, following through with every possible type of multidisciplinary service that's available to you, even if you don't feel like you need it, do it anyway. PT, speech, whatever it is. I think the more Parkinson's specific services, the more skills, the more strategies that you have at your disposal. In addition to daily exercise, social connection, maintaining a daily schedule, having structure, having routine. Sometimes the changes associated with Parkinson's really disrupt the routine. Retirement disrupts the routine. The pandemic disrupts the routine. We need to find a way to superimpose that structure and that meaning and consistency that maybe life circumstances have taken away from us. So structure, goals, exercise, social connections, multidisciplinary care, pleasure, sprinkling joy, finding as many opportunities as possible to sprinkle joy throughout the day. And that's going to be different person to person, as it ought to be. Being kind and compassionate to yourself, talking to yourself, in the same words that you would use to console, your best friend, or a child or a grandchild if they were upset. Be kind to yourself, be caring towards yourself. Take deliberate opportunities to just be in the moment rather than to be in your head throughout the day. So if you're sitting in your backyard, having your breakfast, just spend an extra 5 minutes having that cup of coffee, looking around, noticing the color of the flowers, listening to the birds, listening to the winds, feeling the sunshine on your face, and really pay deliberate, focused attention to what all of your senses are telling you.
Absolutely. Yeah. I mean, it seems simple in some ways, but sometimes like such a hurdle to get started. So I think another thing that you sort of had talked about with that analogy of the fire department was, making the small sort of baby steps towards something that's bigger, right? Like just start with something. And I think that a lot of our folks that are out there, they feel like they don't have something to contribute to people and others, and they shelter themselves away. And, I think that that's true with even aging parents and adults and things in the world, so I know that my parents sometimes are like, well, we don't want to cramp this style. And people love to be around you. They still want you in those sort of social avenues. So I think, taking those baby steps to put yourself out there is just so key. So
baby steps are key. And the other quick thing I will say is when you want to say no, assuming it's a safe activity that isn't going to put anybody in danger, experiment with saying yes and see what it feels like. You don't have to commit to it forever, but try it once or twice and see how you do.
Absolutely. Well, this is
and as far as therapist referrals and manuals, as luck would have it, I actually did write a self-help manual for people with Parkinson's that we use in our research programs. I'd be more than happy to share it with this group for personal use only. It's not, copyrighted or copy protected or anything at this point in time, but if people would like to have access to it for their own personal use, not to be shared with others, I'd be more than happy to make that available.
Wow, that's so generous of you. Okay, well, you're amazing. So thank you so much, Roseanne, for taking the time. And I just love all the information that we heard today, and great to socially connect with you here. We've been speaking a bunch, but thank you for spending the time. And I'm going to pass it back to Andrea for our final wave goodbye.
Yes. So Dr. Dobkin, we always show our gratitude and, share a little goodwill with a goodbye wave. So I invite everyone to turn on your camera. This is our moment of some smiles and eye contact from across the country and the world. So I'll make sure to get that resource that Dr. Dobkin mentioned, and email us at info@pmdalliance.org if you would like that personal copy. So thank you all, and have a wonderful day, everyone.
Bye, everyone.
Bye.
Thanks for having me.
Thank you. Take care.